Next up is Alasdair MacLullich, who's Professor of Geriatric Medicine in Edinburgh in Scotland. He's the lead for the Scottish Hip Fracture Audit, co-chairs the SIGN guidance, the national guidelines for Scotland. He's started training psychology in medicine. He's got a PhD in cognitive aging, and if you haven't heard of him because you're in a parallel session, I'm a bit surprised over the course of the last 2 or 3 days, because he's either been presenting in one or being talked about in the other ones. So I'll leave everything to you, Alasdair.
Thank you, and thank you very much for the opportunity to contribute. I came to an FFN in 2018, and now I'm about to join the executive committee because I spend a lot of my time doing delirium research, but all my clinical work is in hip fracture care, which I've come to really love over the last 10 years, doing this as my main clinical work. And today I'm going to be covering very pragmatic clinical talk. I'm not going to be citing a great deal of evidence in the interest of time, but almost everything I'm saying is either backed by evidence or by expert consensus, so please come to me if you have any questions. I'd like to start with playing a video, and this is of a younger person, a colleague of mine who had delirium, and she describes the distress that she had, but also how she was helped by people, and towards the end she uses a phrase which I've never forgotten. She bravely offered to do these interviews with me, which I've released a couple of them, but I'm hoping to put them together in a bigger package. And even though she's younger than our typical patients, it doesn't matter really, because these kinds of experiences are really common, and I think us as practitioners are in a very strong position to relieve the suffering of people with delirium. So that's maybe my main message for today. So I'll just go to the next slide and play this 2-minute video.
I think it can be easy to overlook or even become disillusioned with the importance of providing these moments of comfort when they can be so fleeting, and you might even witness yourself having provided this moment of what seemed like comfort, and then walking away and looking back and seeing your patient looking distressed again and thinking, oh well, maybe it didn't really make any difference. But that, for me, that memory with that porter, I hope gives people the message that those moments, however fleeting, are important because they stay with you. And it's almost like having a hand reach out through the darkness to remind you that this is not what life is usually like. And the more of those hands that can reach out, no matter how fleeting, I think the better we will be at not only treating delirium, but also more broadly connecting with the humanity of the people that we're looking after.
Yeah, so I think this image of hands reaching through the darkness, we can all be those hands, and instead of talking over people or ignoring them, which is unfortunately the way that a lot of delirium care happens, I'll come to that later, that's really the first thing, is to recognize the individual who's going through this terrible experience. So I'm going to be a little bit about definition, then run through the fundamental pillars, and I shouldn't be using that word in the FFN because we use the word, but aspects of delirium care, and then some thoughts on improving the whole system of care, and then some conclusions. So we have DSM-5, but I think this is a simpler and better definition, just a rapid deterioration of mental functioning. That's the essence of delirium. Nothing else behaves like that, really. Nothing common behaves like that anyway. So if it's acute and it's a change in mental functioning, it's 99% of the time going to be delirium, and it's triggered by many different causes, most of them outside the brain, hip fracture being a big one in itself. This definition was suggested to me by a nurse during a Q&A after a talk, and I really like it in terms of a teaching thing. Is the patient different? Let's keep it simple, especially over short periods of time. That is nearly always going to be delirium in inpatient settings. Interestingly, I think our understanding of hip fracture prevalence in delirium has changed over the years, because it used to be higher, I think. Now I think, modern data show around 20% on admission, and it used to be said 50% post-operatively. That's because they fasted for 4 days, were overdosed with morphine, treated really badly. I think as care has improved, the rates have come down, and around a quarter, I would say, with healthcare systems with decent care, that's the kind of levels we see. Older people who are frail with dementia are much more likely to get delirium, but really anyone can get it. It's a condition that we know from many studies over the years has lots of acute and chronic adverse effects. Some of them, the acute ones, I've mentioned distress. People have much higher rates of pneumonia, which is a big cause of death in hip fracture patients, actually. Increased length of stay, much higher risk of not going home. A recent paper in hip fracture showed that in JAMDA. Readmission rates are also higher. Recovery is more difficult. So it's something that we should try and avoid, but when it happens, which often we can't prevent it, then rapid recognition and treatment is really very, very important for hip fracture patients. We don't have much up-to-date data on how long delirium lasts. It used to be said it was 3 days, the duration. We've done a study recently which showed it might be a bit longer in older people, maybe 5 to 7 days. But it's a very wide range. I see patients, I'm sure you do, who have delirium for half a day. And then if you recognize it and treat it quickly, find the cause, that we can get better right away. And that's great when that happens. Other people have terrible delirium that just goes on no matter what you do, and it's a bit of a mystery what it is. Another important thing is that about a good number of people have very persistent delirium that can last for weeks or months and kind of merges into an unlabeled state. It can't really technically call it dementia because it's too short. It's got to be 6 months to be dementia, but we don't really know whether these people have had some form of inflammatory or ischemic brain injury around the time of surgery, and they just don't get better. So that's something that medicine has not yet managed to find the answers to, but it does exist. I think we've all seen it. Now, I'm sure people here are aware of this, but it's maybe a message to bring back to your colleagues, just to always be careful about the technical differences between delirium and dementia, because they still get mixed up. And of course, the treatment's different, and how you talk to families is different with delirium versus dementia. Many families think when delirium comes that it's dementia. So just be aware of this and emphasize this, in your practice, especially the reversibility. So now I'd like to move on to detection. So although the DSM-5 criteria will talk about inattention and arousal, in fact, in real life, delirium presents with many different ways that doesn't automatically have a label across a patient's head saying, I have inattention. And I think it's quite useful just to always be aware of these kinds of differences in behavior that can be different. NICE guidelines actually cover this really well, by just a change in function, anything that's different about the patient. If you look into these patients, which we've done in some of our work, they nearly always have inattention if you measure it. But how it looks to somebody at the bedside might not look like inattention in that obvious way. And in terms of what we do in practice, there's two broad scenarios that we need to think about. And I don't think this has been covered that well in our literature and teaching. The first is the sort of new presentation, or the times of high risk. So somebody coming into the ED with a hip fracture, it's very important that we know straight away if that patient has delirium. How can you tell that? And the other scenario is in patients who don't have delirium when they've come in and they get it down the line at some point. So these are different problems to solve, because people with high risk of delirium may get it 5 days in. So what are you going to be checking for delirium using the same tool for the whole time they're in hospital? So let me talk that through. So I think there are two main ways that we get to making sure we haven't missed delirium. So there's a high risk point, so that's admission. In hip fracture care in Scotland, what we recommend, and I'd back it very strongly, is to do it on admission to the ED. Even, in fact, as we heard from Ellen Saga earlier, if the paramedics can do it at the site where the patient has had the hip fracture, that's even better. on admission to the ward, so that could be hours after ED presentation, and things could have happened in that time, and then post-op at least once. Post-op day 1's probably the best day to do it. And then after that, we need some sort of other system where you're going to be looking for delirium, especially in high-risk patients, over time. And I don't think that the 4ET done for 5 weeks, 4 weeks, 3 weeks, every single day is a good system for that. I think it's too burdensome. Other systems that claim that they do that, like the CAM or the BCAM, I've spoken to real-world, settings, and nobody's asking months of the year backwards, or will a stone float on water twice a day for 4 weeks in any ward in people without delirium. That just isn't happening. They say it's happening, it's recorded, but it isn't happening because everybody knows it's silly to be doing that, and it's burdensome and it's exhausting. So what you need for monitoring is some kind of observational process. Plus, I think, and I'm increasingly coming to the belief that something like the SQUID, done twice a day is a good thing to have as a safety net. But I actually think an educated workforce that knows that a change in the patient could be delirium, that's the answer. And then you deploy a 4AT or whatever tool you like after that. But I think rather than a system that's enforced, forced on a staff group, let's just know what delirium is. And I think nurses are excellent at detecting delirium. It's just a question of saying this is what delirium looks like, and then the nurses know the patients. Physios know their patients, especially they're coming repeatedly, OTs, other staff. Doctors, maybe a bit less so, especially if you're senior doctors, see the patients less. So this is another way of describing it. So high-risk patients, at strategic points, a more definitive tool, and then a monitoring system in place. And the website has the details of the 4AT there. The SQUID, the single question delirium, has got the best acronym in medicine, I think, and it's taken off, I think, partly because of that, but also because of its very good face validity, so I think that's a useful thing to do. Recovery is something that patients care about. We know this from Rose, who's here, did a PPI group and found that many patients express this wish of really wanting to get back to normal from delirium, but we're not very good at this. It's not been studied very well, so once you've detected delirium, I think the plan should always include some kind of plan for repeated assessment. A study we've just done, we haven't published it yet, showed that repeated 4ATs in patients with delirium, as opposed to screening for new delirium, was an effective way. And the specific features can be quite a helpful way of monitoring whether that patient's getting better. So now I'd like to move on to treatment. So this 8 aspects, Delirium 8, comes from the SIGN guidelines, looking for acute life-threatening causes, and once you've done that, so this could be like severe opioid toxicity. This could be just the long list of different things that it could be that maybe you're not having to rush to do, and then optimizing conditions of brain recovery. These are the 2 fundamental things that you'll probably read about, but then there's these other things that I think should be done as well, and this is really derived from the SIGN guidelines. So often there's more than one cause. That's very common in hip fracture patients, isn't it? Analgesia, pneumonia, and so on. So look for more than one cause. That's what geriatricians do, but maybe not all physicians think like that. Many different possible causes. I don't have time to go through them all now, but it takes me time, and I've done this a long time. I think I'm about average speed. I'm not super fast, but I don't think I'm super slow, and it takes me half an hour to properly see a new hip fracture patient with delirium, to think about all the things and make a plan, communicate the plan, speak to people. It takes a while. It's just inevitable. 50 or 60 variables you're considering, and if you're doing it in less than time, it might be a genius, it might be a simple case, but it's probably missing things. Optimize brain recovery. This again needs a systematic approach. And then the next thing I'd like to talk about is distress. So this is something that's so common in hip fracture. I mean, in wards, people screaming, you walk down the corridor, sometimes it's because there's a moment of transfer happening, and other times it's just unaddressed distress. So pain's very common. We have this on our website, shfa.co.uk, I think it is, but you can find it. We've got a pain assessment. I think optimal management of pain, so you don't overdo the opioids, but you give enough. It's very hard to do, and it requires skill, but that's a critical part of treating distress and delirium. And then there's all these other things. So common, isn't it? 1 in 4 patients get retention, and haloperidol is a really bad treatment for urinary retention, isn't it? I mean, it's not going to make them pee. and it's often missed, and people are, writhing around, and some well-meaning person saying, oh, they're agitated, give them some haloperidol. So pain, all these other things, that need to be dealt with that aren't going to respond to haloperidol or analgesia. And my colleague Sharmila, who gave that interview, gave an example of speaking therapeutically to somebody with delirium, hands reaching through the darkness. So this should always be what we do. It's quite possible everybody here is doing that anyway, but I think it's the case that we just don't optimize this opportunity to help somebody with delirium by offering them comfort, explain that it's delirium, tell them what's going on, ask them about hallucinations, say that it should go away with time. It's incredibly powerful, and I'm hoping to do some studies on this because I think it's actually a missed trick in delirium care. It's better than just whacking in the haloperidol. I mean, I think that drugs can be used for delirium. I'm not anti-drug, I just think in a minority. And I probably see 10 or 15 patients with delirium a month. Maybe I use drugs once a month for delirium, something like that, So it should be a rare treatment, but it should be there if the distress is intractable. So communication with patients and carers is prevent complications. Sorry, I should have mentioned, pressure sores, dehydration, malnourishment, immobility. Many things can happen to that vulnerable patient. The communication side, giving a leaflet, probably each of your healthcare systems has delirium leaflets. A very simple, very powerful intervention. Monitor for recovery, I mentioned. Continuing the rehabilitation, increasingly physiotherapy and OT groups are seeing, ongoing rehab. Actually, the rehab treats the delirium as well as helps the recovery from rib fracture. It's a very helpful thing to do because physios and OTs are extremely skilled at patient interaction, and that engagement and that human contact, I think, is actually very therapeutic. But that's for another talk. And then also always consider whether the patient could have underlying dementia that's not been diagnosed and think about some kind of follow-up. So prevention. Now, this is just one slide, but there's quite a lot on it. And the reason I've decided not to spend a great deal of time talking about this, because a lot of it is just, it requires common sense, systematic, diligent, conscientious nursing care, where you avoid dehydration, malnourishment, somebody not knowing where they are, somebody not sleeping because of noise, somebody being in pain, somebody having untreated infection. During operations, maybe, depths of anesthesia monitoring seems to work a bit, and that's coming out in a few guidelines, optimizing medicine. But some delirium can be prevented with, and most of it is about avoiding hospital-related harms. So I think there's probably not much more to say than that. There's systems of care like HELP, which have instituted that, but I think if you're working in a hospital where you can just have this as routine, the thing is just to make sure that's happening well. So just some last comments. So I think in terms of improving delirium care, we have come a long way actually from people barely talking about delirium 20 years ago to being something that we talk about much more in some countries. And we've got there through a lot of different, a lot of effort, which has come through lots of talks, hundreds of talks in my case, chapters and systems, policies, government getting involved. So education, I think, is the core one. There's no point in trying to do a lot of this if the average junior doctor, staff nurse, or physio doesn't even know the definition of delirium. And it's not the fault of these people. If they haven't had it in undergraduate teaching, then it's the fault of the people that designed the programs. So anyone, especially here, who's got some responsibility for teaching, let's just make sure that that's embedded in this very common serious complication. And then this whole other program of pieces of work, many of which we're doing with hip fracture, should always have delirium included. And I would make a statement that I think it's time that we just abandon the idea of having registries without delirium. Does everyone agree with that? Does anyone want to avoid having delirium in registries and audits from now on? So that era is over now, do we all agree? From now on, we always have delirium in our registries. We just need to start including them in whatever way you choose. Good, I'm glad we have an agreement on that. And also at the front door, not just post-op, because that's UK, that's now England and Scotland both do that. Education is a critical way of moving this forward. This is a study from Australia, Andy Theodorchuk. Not only improves knowledge, but also outcomes. So education is a very important intervention for delirium in general. All of this stuff works. This is Scottish data for the whole population. our coding of delirium at discharge is quadrupled since 2012. And that's, the NICE guidance from England, we used them. We have our own guidance, came in 2019, so that didn't affect it. But NICE guidance was very catalytic. And so this effort works, so let's keep going. So it's a very complex challenge. I think people who work with hip fracture patients are in a good position to help people do them because they're used to complexity, they're used to frail people, they're used to communicating and helping people in very difficult crisis in their life. They're used to being kind to these people. We have to make sure we detect it, call it delirium, think about the complexity of the detection or of the treatment. Where possible, try and prevent it. If we're trying to improve delirium care in our systems, always think about the whole system rather than just saying, let's do a few delirium lectures. Where are your audits? Where's your QI? Where's your policy? And education really has to be the heart of that. Several resources there. I'm happy to share the slides. Delirium Day is the World Delirium Day website, and this is the last slide just to advertise some various delirium items, including the EDA meeting in November 2024 in The Hague, which anyone here interested is welcome to come to, or in your own countries. Thanks very much.
We're running really quite short on time, largely because of the success of delirium in impregnating the entirety of our work. And I sort of agree with you that we're really now running a pathway of delirium avoidance, part of which is fix the hip. We've got one question.
Thank you very much for your talk. Interesting. You have a wish of having delirium in the registries. You have a wish of having delirium registered in registries.
Yeah.
Yeah. So, is it feasible? Will it be a registration with high quality? That's, I think, is the requirement of having such a parameter in a registry. And I doubt that we'll get a high quality so we can use it maybe with each department, but not across.
Okay, well, I'm glad you asked that because in Scotland we do 91% 4AT completion in hip fractures. We know that the rate's 20% positive, so it's certainly possible. You just need commitment, you need focus, and it can happen. It might take a few years to build up the workforce to understand it. In England, with this,
we've got
96%.
We've got 87% post-op. We're going to have pre-op and post-op in the UK from January. Very good data, very good quality, and research papers being written off the back of it.
Yeah, but have you validated the registration of it? That's the key issue.
Yeah, I mean, it's all registered, it's all public data, we can share it with you.
Yeah, but you have to be sure
possible.
that what you register is correct.
Sorry?
You have to be sure that what you register is correct.
Yes, well, I mean, we use tool, the 4AT's got the most validation of any delirium tool. It's got good sensitivity and specificity, and of course, a rapid screen tool done by lots of different people is going to have some inaccuracies compared to a psychiatrist spending half an hour. But overall, and we know from a type of validation is the outcomes, and both Anthony and I have done research, with Rose, like my colleague that I think
we'll show you afterwards.
Thank you.
Move on.
Yeah.
Thanks
So it's a challenge, but we've shown that it's possible. Okay.
Thank you.
Is that the?
Our next speaker will be Peter van den Berg. He's